Hello everyone, so I have a full queue of CT scans to report. Let's grab the first one, because as you guys know, these exams won't report themselves. So I have already downloaded, because this is the third time I tried to record this video and I was interrupted all of those other tries. So let me share my screen with you guys so we can continue. Yes, so I won't fake surprise because I'm not surprised anymore, but you guys are going to enjoy this, I'm quite sure. So this is a female patient. She is 83 years of age and she has gone through some kind of surgery and had an allergic reaction. So for some reason the doctor at the emergency department ordered a CT scan of the chest. Of course it's unenhanced because reasons. So let's go. This is a soft tissue or mediastinal window right here, and this is a recon and a lung window. So as you guys can see, this isn't a normal scan. I'm just going to roll up and down the image so you guys can have a idea of what we are facing here. So I'm going from apex to base, and this is it right here and right over there. So I'm pretty sure you guys already saw trouble here. So let's start, because we have to start somewhere. We're going to go as usual from outside to inside, and we are going to, in the end, summarize our report so it makes more sense to the referring physician. So soft tissue, outside soft tissue is fine. We have a bunch of degenerative disease on bone. This is quite typical of the elderly. So I'm just going to hit some MPR reconstructions right here so we can look at the sagittal view. Sagittal is really nice to look at the spine, search for anything really. So also it's nice to see the rib cage. Ribs on the right seem fine, and ribs on the left also. So in cases of trauma patients, it's really nice to look for sternum fractures or dislocations, and the coronal plane is best for studying the clavicles, the collarbones as you guys call it, for fractures. It's quite as common as rib fractures, and it's very easily missed if you don't do the proper reconstructions or if you don't pay attention on the axial view. But on the axial view you are usually very concerned about other stuff and not bone, so be aware that you may lose stuff. And most sternum fractures can be missed on the axial view because it follows a perpendicular plane to the long axis of the sternum, so it's much easier to lose. And here in this case we aren't losing anything on bone. Bone is fine, just degenerative disease that is quite common at her age. Let's just pay another look at the breasts. So breasts seem symmetrical, and there is no sign of thickening of skin, no densification of the breast bodies. So axillary regions look okay. they are fine. And next we are going to look for pleural effusions. Are there any pleural effusions? No, no pleural effusions. The pleural space is preserved. So fine. So I know you guys are screaming on your chairs, say, come on, report the masses, pulmonary masses. Calm down. Let's look for anything else before we go to the most obvious lesion, which is right here and right here, so we don't actually miss anything else that is of importance. Also, there is enlarged lymph node, secondary enlarged lymph node. This is a terminal case. This is a very, very serious case, a advanced disease case. I don't know why this patient doesn't have a diagnosis so far, because this is quite easy to look at in any simple chest x-ray, but still this patient has gone through surgery and a bunch of procedures and has gone through the emergency department, and still no one had noticed this humongous pulmonary cancer right here and a secondary lesion right here, which is kind of the same but a bit different, but should be the same presentation, another presentation of the same disease. So let's look for pulmonary lesions, not tumor. So we can see, I'm just going to, oh, no need for that. I'm just going to go for one view, grab here, so it is easier for you guys to see. There is emphysema. Yeah, it's centrilobular emphysema, mostly on both superior lobes, and we also have subpleural lobes of air like this. We also have some bands, pulmonary bands, which is fibrosis, much common on the apex of the superior lobe. It's most commonly a symmetric presentation. In this kind of presentation is residual. This is scar tissue, and it's also really common on the medial segment of the median lobe, and of course on the inferior segment of the lingula. So, and this is it. This is what it is. No pleural effusion. So I have right here a pulmonary mass on the superior left lobe. It is a solid mass because it has soft tissue attenuation, so it's solid. It has clear, it has spiculated margins, all irregular or spiculated margins. It's an infiltrative disease because it takes over the mediastinum. It goes around and infiltrates the walls of the great vessels. It also encases the airways, and this is a very typical secondary stenosis of the lobar bronchi right here and right here. So this isn't really a benign lesion, this is a malignant lesion. There is also eccentric calcifications. There is a bunch of secondary lymph nodes, 1.3 centimeters on the short axis. Also, you can see signs of lymphatic extension of the tumor. We have smooth thickening of interlobular septa, right there. This is lymphangitis, carcinomatous lymphangitis. This is lymphatic extension of the tumor. The tumor is huge. I can barely see its limits, but I'm going to try a measurement right here. It's about 7.8 by 55. It doesn't really matter much because it is a huge advanced disease, so I'm just going to write it down so I don't miss it, I don't forget it. Lymph nodes. So this is a central mass that takes over mediastinum, great vessels, pulmonary ileum, and airway. So this is advanced, unremovable, unresectable disease. And we also have another lesion quite like that one on the basal, posterior and medial segment of the left inferior lobe. So this is the mass right here. It is 54 by 44. 54 by 44. It's solid. It has regular circumscribed margins and some peripheral calcifications, but since it's huge, it's an old patient with emphysema that has another quite similar tumor on the upper lobe on the same side, we should consider this one as being the same presentation, another presentation of the same tumor. It's much easier not to make a mistake if you think like that. So we also have secondary enlarged lymph nodes on the mediastinum. We have diffuse calcified atherosclerotic plaques all over the aorta and on the coronary arteries also. There is no dilatation of the vessels are fine, no new consolidations, no pleural effusion secondary to tumor invasion yet, and no bone lesions, no secondary bone lesions. If we scroll just a bit down to the abdomen, we can look for secondary tumors on the adrenal glands, no such thing. So this shouldn't be a very aggressive kind of tumor. This should be a slow growing, less aggressive, less undifferentiated tumor, but nonetheless this is advanced disease, a very, very serious disease. So let's report, because as you guys know, this exam won't report itself. So I'm going to start by reporting the chronic lesions, and then I'm going to report the tumors. So it's emphysema, bands, and subpleural globes of air. So now the pulmonary bands, and now I'm going to report the masses. It's over 3 centimeters, so this is a mass. Spiculated margins, and it measures 7.8 by 5.5 centimeters. Superior left lobe, left superior left upper lobe, and there is also another mass right there. This is the basal posterior segment of the inferior or lower left lobe. So it's taking over most of the segment and has quite the same presentation of the first mass. Now I'm going to report the secondary lymph node enlargement. 1.3 centimeters on short axis. So let's summarize the report, make it easier to read. So I just summarize it as pulmonary masses on the left. So pulmonary masses on the left. Summarize it quite well. And we are done here. Let's just finish it, sign it, and move to the other exam. So if you enjoyed this video, I'm pretty sure you're gonna enjoy this one right here. Just click here and keep watching. Thank you so much for watching, and I'll see you on the next video. So long.